Good evening. Good to see everyone. This meeting is being live streamed on YouTube, and we will be adding the YouTube link in the chat so you can share it. We are offering simultaneous translation from English to Spanish and Spanish to English. That means please look at the icon of the globe at the bottom of your screen and choose the channel in which language you want to hear this webinar. So for everyone who's joining, please make sure that you click the button at the bottom, the little icon, for choosing your channel for English or Spanish. We are having a wonderful lineup of speakers this morning. I'm very excited to see that we have, sorry, I'm just putting our last speaker into the panel. So here we are. Now we have all our speakers lined up. Thanks everyone for joining. Hi Paco, sorry about that. I'm glad to see that you're now in the panel. So you ended up as attendee instead of in our panel, but that's all okay. All right. Welcome everyone. We are talking today about our frontline healthcare workers. Last week was International Nurses Week, World Nurses Week, and it's the perfect time with everything that's happening in the world. We had the UN Assembly talking about TB, universal coverage, and pandemic preparedness, and the focus very much was on the healthcare workforce. And it's really good to see that we want to make sure that our frontline healthcare workers get the attention and are at the center of all our programming. So today, as part of the TBPPM webinar series, we are looking at who are really the frontline healthcare workers that are looking at ending TB. And we are having a fabulous lineup of speakers, and I'm really pleased that we have 1.5 hours. For those of you who have just joined, please choose your channel in the bottom, English or Spanish. We will be recording, we will be making a report, which we will be making available to everyone. And for the content and for the moderation, I'm very pleased to hand over to my colleague, David Bryden. David is the director of the Frontline Healthcare Workers Coalition. He has been a fierce TB advocate in the past, and so he knows both fields, tuberculosis and the healthcare workforce, really well. And he is the best person to be moderating this webinar today. So I'm excited to hand over to you, David, to introduce the speakers and to moderate the discussion. Thank you so much for taking this on today.
Thank you, Petra. I'm so excited to be on this webinar today and lead this discussion. Welcome to everyone, all of the participants around the world, to this really exciting session that we have with 4 dynamic speakers who bring different perspectives on this issue. We're going to be looking at a number of really critical topics, and the overall goal that we all share is how do we get services of TB to everyone in need and make sure that those services are high quality and people-centered. But one of the aspects that we need to delve into is how do we get all hands on deck, not only the public sector workers, in public health systems, but also the private providers. How do we engage with them and make sure that they're engaged and supported to actually reach those goals, trained and supported properly? What are some of the health workforce needs that we really need to attend to, given all that we've been hearing from WHO about health workforce shortages getting worsening in some regions, or not improving in some regions, and migration of health workers increasing from low and middle income countries to high income countries. So we're going to be looking at some of those issues, talking about the pharmacists, the community health workers, the private doctors, physicians, nurses, health workers in large hospitals. All of these efforts, all these personnel are needed to engage and equip all providers to reach people in need. We're going to be talking about the importance of integration with primary health care. That's a really important topic. And I wanted to just, Petra, you mentioned the really important multi-stakeholder hearing that took place last week at the UN and some of the demands that were brought forth by the community. And if you look at some of the demands, there was some really clear call to commit to investing in ensuring the appropriate numbers and distribution of health workers across all forms of TB care, fully compensating and supporting the community health workers, and integrating TB services as an essential component of universal health coverage. So there are a number of really important issues that were brought forward at that multi-stakeholder hearing. And go to the Stop TB website for some information about how that the demands that were taken to that event. I had the pleasure of attending, and it was really exciting to hear the community voice there for high quality, people-centered care. So we've got 4 fantastic speakers. Each of them has 10 minutes. I want to remind the audience, keep thinking of the questions that you want to ask once you hear these presentations, because we will have 20 minutes at the end. If you look at your screen, you'll see at the bottom, there is that little button that says Q&A. So that's where you're going to be putting in some questions. You see that Q&A button? Okay, have a look at the bottom of your screen. It says Q&A. That's where you're going to be putting in your questions. You also see chat. Chat's for hello, my name is, and great job. You also see reactions, and so you can give a thumbs up there if you want to. So we've got some fantastic speakers. We're going to start out with Hannah Monica Diaz from the World Health Organization's Global TB Program. She leads the work there on advancing multi-stakeholder engagement and accountability, including sectors beyond health, to address the key drivers of TB and strengthening the public-private sector partnerships. And then we're going to hear from Francisco Rodriguez Garza, also known as Paco, who specializes in strengthening health systems at a global, national, and local level. He's the senior manager in advocacy at Last Mile Health, where he focuses on the development of policies and mobilization of resources in Africa for the professionalization of community health workers and strengthening primary care delivery. Then we're going to hear from a nurse. Daniela Puma Abarca is a registered nurse and public health professional who leads several TB programs for Socios en Salud in Lima, Peru, also known as Partners in Health, Socios en Salud. Then we're going to hear last from Ramya Anantakrishnan. Dr. Anantakrishnan is the director of a nonprofit organization called REACH. She's a medical doctor with a master's in community medicine and has been working in the field of TB for the last 19 years. So we have some fantastic speakers lined up. Again, have a look at that Q&A button at the bottom of your screen. Start thinking about questions and comments that you want to make. And I'm going to turn the floor over now to Monica Diaz from WHO. Over to you, Monica.
Thanks so much, David, and warm greetings to everyone who's joined from around the world. Let me quickly try and share my presentation. Please give me a minute. David, may I ask you to please confirm that you can see the full slide view? Okay, perfect. Thanks so much. So what I'll do now is basically, I mean, David and Petra have both provided an excellent introduction. And from the WHO, World Health Organization perspective, I'd like to share with you the work that we're doing on engaging all care providers on the road to universal health coverage, on the road to pandemic prevention, preparedness, and response, taking as a strong case study or a tracer the work that we are doing on ending TB, which we've been undertaking for the past several years. So let me just reiterate the importance of human resources for health, and this comes from WHO and a lot of studies that have been done. We all know that there is a massive healthcare or health workforce shortage, a lot of which results from underinvestment in this area, and it's been further magnified by the pandemic. This has, of course, led to inefficiencies in health systems, and this is why we're pushing towards universal health coverage, because this is one of the major roadblocks or barriers when we are looking at looking at ensuring access to care for everyone everywhere. The COVID-19 pandemic, of course, made matters worse, with the health workforce being stretched to its limits. There have been several studies undertaken by WHO, which estimated that 150,000, this is 2021 data, healthcare workers lost their lives to COVID-19. So we see this massive loss of the health workforce. In addition, several pulse surveys have shown how health worker capacity has been diminished during the pandemic, mainly due to burnout, stress, anxiety, insomnia. The frontline healthcare providers have taken the brunt of the pandemic, as we all know. And this is one of the largest constraints to ensuring access to essential healthcare services, including for infectious diseases like TB. The scale and scope of these challenges requires that we basically develop a pathway with a clear set of actions when we look at the TB response, when we look at the healthcare response, or if we're looking at a future pandemic preparedness. WHO has for member states, and all member states have agreed to this strategy on human resources for health with key objectives outlined. However, again, due to the COVID-19 pandemic, due to investments, mainly a lack of investments, we're not seeing the full implementation or full scope of the objectives and outcomes envisioned by the strategy really reached. The strategy very clearly highlights the need to optimize the health workforce. It recognizes the need to engage all sectors, public and private. It also talks about strengthening data around the health workforce. And all of these are critical as we look at getting on the road to achieving universal health coverage. So coming back now to UHC and ending TB and other infectious diseases and addressing the drivers of the epidemic, let me remind you of some key factoids. And looking at it, so when we talk about engaging all care providers and taking here for putting the spotlight here on the private sector healthcare providers, and we know that in several settings, and there's data on this, that the first point of care is often a private care provider or an unengaged public care provider or an informal care provider. This could be a private practitioner, it could be a pharmacy, it could be a traditional healer. Often this is done for ease of convenience, the timings of private sector care providers, location, fear of stigma and discrimination. These are some of the reasons. Unfortunately, while we know these are the first points of care, the private sector care providers are often not fully engaged in universal health coverage or in the TB response. And the drivers, when we look at addressing the drivers of the epidemic, including poverty and undernutrition, HIV, diabetes, tobacco, alcohol use, we need to make sure that all sectors are engaged, especially the private sector. And if we are looking at truly ending the TB epidemic or achieving universal health coverage. Now, with TB in the spotlight, we know that, I mean, these are facts that most of you know, nearly 10.6 million people fall ill with TB each year. We know that 4.2 million people miss out on access to life-saving TB prevention and care services. Now, we know majority of the 4 million, approximately 4 million people access care either in the private sector or unengaged public sector. So this is underlining why engagement with the private sector and other care providers is a must. Likewise, with drug-resistant TB, of the close to 500,000 people estimated to develop drug-resistant TB annually, only 1 in 3 access care. Again, a gap which can be addressed by engaging all care providers, including those in the private sector, community, and unengaged and other sectors. Likewise, with reaching kids and children and adolescents, again, here you can see that the gap is even wider. Over 500,000 children miss out on access to quality care. We know that, again, most people with kids will access care in the private sector or in the maternal and child health sector, reaching out to pediatricians or, in parts of the health program that are not necessarily linked to national TB programs. Again, here, engaging all care providers is important. Likewise, when we look at reaching the targets on TB preventive treatment to address TB infection, huge gaps remain, and public-private mix or engaging all care providers is key to closing that gap. So that's basically our underlying premise. And for the past 2 decades, actually, in our work on the fight against TB, we've been consciously pushing for the private sector, private healthcare sector to be engaged in the TB response. And we can clearly see the benefits of this. Looking at TB case notifications and the contribution of the private sector, if we look at the big 7 countries with a high burden of TB as well as a large private sector, we call them the big 7 PPM priority countries. You can see that there have been, over the past 10 years, since 2010, there has been a huge a jump in notifications or in reaching people with care. You can see this very clearly in the case of India, Indonesia, Pakistan, for example, Nigeria. You can see that the jump, the contribution of public-private mix or public-private collaboration is quite significant. You will also see in some cases, for example, the Philippines, there's been a drop. For example, in 2020, or in the case of Indonesia, for example, you can see this very clearly, or Myanmar. Again, the drop has been mainly due to the COVID-19 pandemic, where in several settings, the private sector wasn't engaged, and you could see that there's been a significant gap in reaching people with care. So in the TB response, we have 2 tools. One is a PPM roadmap, a public-private mixed roadmap that we advocate for, which as well as the landscape with good practices. Both of these are good references that we will share in the chat with you. The roadmap basically outlines 10 key actions. It's been developed by the Public-Private Mix Working Group. The World Health Organization hosts the Secretariat. And then it's a working group of Stop TB and a mix of global partners. It recommends, the roadmap recommends 10 priority actions, going from building an understanding about patient preferences, private sector dynamics, rationale for engaging all care providers, to setting ambitious targets, what measures gets done. So this is really important. We also have targets on political commitment, on investments, on strengthening intermediary agencies, so that to take off the load of national programs, the need for establishing flexible models of engagement, harnessing the power of digital technologies, as well as those of the regulatory and policy environment, the need for adequate incentives, and importantly, through it all, you'll see on top this, the importance of monitoring progress and building accountability, which is also a part of what WHO has been promoting since the first UN high-level meeting on TB, on this need for multi-sectoral engagement and accountability. We released an accountability framework in 2019, which really looks at the big picture and holding member states accountable for the commitments made, the community as well, to hold everyone accountable, to make sure everyone is engaged. As part of this, for public-private mix, to measure the contribution of the private sector with the support of the Bill and Melinda Gates Foundation, we've been working on developing data dashboards to improve visibility into private sector collaboration, increasing accountability for PPM in priority countries, and strengthening programs. So to conclude, I'd like to maybe touch upon a few things we've just released. WHO has released a new technical brief on engaging the private sector for universal health coverage and health security. I urge you to read this. But basically building on the lessons that we've learned in the fight against TB and in strengthening the TB response through the engagement of the private sector and all care providers, it's really important that we follow these steps, which basically are a summary of what builds on also our roadmap. One is, of course, having an inclusive health policy that sets out a good rationale for private sector engagement with clear roles assigned. Disaster preparedness, and this is another lesson that we've learned from the pandemic, and Petra can share the PPM Learning Network pulled together this nice document summarizing the impact of the COVID-19 pandemic and the private sector, and it really shows the harsh impact of not having the private sector engaged in certain settings, and how engaging the private sector could have boosted a lot of the response. We also highlight the need for establishing regulatory provisions, clear care and referral pathways, affordable emergency care. So as we look at pandemic preparedness and response, this will be important. Investing in health information systems, data is important, as I showed you from the dashboards. All of this work is also a priority in our Director General flagship initiative that was launched in March, where we are marching towards universal access to TB prevention and care. And this is really going to be important as we move towards the 2023 UN high-level meeting on TB that will happen on 22nd of September 2023. The health workforce, strengthening of the health workforce in efforts to end TB and on the road to universal health coverage and pandemic preparedness should be prioritized across all the agendas of the high-level meetings on ending TB, universal health coverage, and pandemic preparedness. So I'll stop there, and thank you very much.
Great. Thank you so much, Monica. That was really a very useful overview of what we need to do to engage with the private sector providers in particular, and the successes. In a number of those countries that you mentioned, we often think of Asia as particularly the focus, which is true, but you included Nigeria there as well. And what happens when you actually invest in this PPM mix and the results that you can get, but also the drops that we've seen, as you mentioned, in the Philippines, really suggesting we need to intensify work there. So I'm going to turn it next to Paco from Last Mile Health. Paco, looking forward to your presentation today. We're going to tell us about the exciting work that you're doing in the African region, strengthening the community health system and the community health team, including the community health workers. Over to you.
Thank you, David. Hi, everyone. Good morning, good afternoon, wherever you are. It's great to be part of this opportunity. I didn't prepare any slides for today. I would really like to share a little bit of my experience working in tuberculosis, both in Mexico and also in some regions in Africa. I must say that I was very energized to attend the WHO Human Resources for Health Forum last month in Geneva. I think that for those who weren't there, I left the forum very energized by the commitment and recognition of that a lot of member states and government representatives had for primary healthcare providers. And I think that's a key element that we have been overlooking over the last couple of years or last few years in terms of the prevention, detection, and treatment of tuberculosis. Which makes me, think about how we have known the bacteria that causes tuberculosis for over 100 years. Historical data also shows us that it has been around us for at least 9,000 years. So, this is a long history. It's a known infectious disease that has been alongside our history. And it's well understood to us as humankind. And we have to recognize that great progress has been made to eradicate it. However, progress hasn't been even, it hasn't been just, it hasn't been equitable across the world. As an example, in the 1600s to the 1800s in Europe, tuberculosis caused 25% of all deaths. That's 1 out of 4 deaths throughout this 200-year period. However, today, in 2023, over 80% of cases and deaths of tuberculosis are in low and middle income countries. This is a huge shift and a huge discrepancy of where we're having this burden of disease. As a medical doctor, I work in the south of Mexico, providing primary care to coffee farmer communities who live at the top of mountains, where the nearest clinic usually was a 4-hour drive on dirt roads. That's when we didn't have we were out of the rainy season. And then you had to add another 3 to 4 hours to get to the nearest hospital. So you can imagine the challenges we had and our communities had when they became sick, not even say getting diagnosed or treatment or the follow-up. So during this experience, I was able to diagnose and treat many patients in both urban and rural settings. I've seen the countless challenges patients face to overcome to see a health provider. That can be a nurse, a community health worker, a physician. There's a great variability in this type of regions of the type of health providers our patients can access. And I've seen firsthand how many of them join the almost 4 million patients per year that are missed by the healthcare system because they were not able to be diagnosed, treated, or reported. This is 4 million every year. So we know that tuberculosis is a relentless infectious disease that continues to claim lives despite the significant progress made in its prevention, detection, and treatment. But it doesn't have to be this way. In the middle of this challenging landscape, there is a group of unsung heroes who are making significant impact in the fight against tuberculosis, and those are community health workers. These dedicated individuals are often local residents who get nominated and get voted by their communities for their deep understanding of the cultural, social, and economic context in which tuberculosis thrives. In settings where resources are scarce and access to healthcare is limited, community health workers play a crucial role in bridging the gap between the healthcare system and the communities they serve. Community health workers are the vital link in tuberculosis detection. I can give an example. So during my time in Mexico, I work alongside community health workers conducting door-to-door visits. So we used to go out of the clinic into the households of each of the members of these communities, screening for tuberculosis and other infectious diseases. And we were engaging with the community members and raising awareness about the symptoms and risks of the tuberculosis. And very interestingly for me, was that in between the household visits or over a coffee break at the clinic or after finishing a day's work, they will often tell me which of their neighbors were at risk for tuberculosis. And this happened after, having a facilitation where we learned about the symptoms that present on early stage tuberculosis or later stages as well. So that really informed my plans and my colleagues' plan for household visits and really making sure that we were reaching out to them despite the challenges that we may encounter. So the impact doesn't end there. Once a person is diagnosed with tuberculosis, community health workers continue to play a crucial role in the treatment, adherence, and support. They provide education on the importance of completing a full course of treatment. and help patients navigate the challenges they may face during this period, such as the stigma associated with a disease. And this key role can help us both prevent the spread of tuberculosis, as well as reduce the incidence of MDR-TB, or multi-drug resistant tuberculosis. They offer unwavering support to individuals and families to stay committed to their treatment, and they improve the treatment outcomes. And furthermore, community health workers are at the forefront of the prevention efforts. They engage in outreach activities, as the ones I was mentioning in the household visits. They organize community events, and they conduct educational sessions to raise awareness about the importance of infection control measurements. And their advocacy extends beyond individual households to schools, workplaces, and other gathering places that are known to bring the community together, where they can discuss and share the problems and solutions for during their gatherings. So they make a lasting impact on the overall health of the community. All of this is to say that it's important to recognize that community health workers are compassionate individuals who bring empathy and understanding to their work. They build trust within communities, addressing fears and misconceptions surrounding tuberculosis, and dispel myths that hinder progress. They serve as a bridge. That last bridge between the healthcare system and the communities and the patients is done by community health workers. They treat individuals with respect and dignity, and they create an environment where people feel safe and supported, which is essential, as we know, for tuberculosis control and elimination. So community health workers are really the backbone of tuberculosis detection, care, and prevention in resource-constrained settings and many low and income countries. However, despite this essential work, community health workers are very often undervalued and under-recognized. For example, in Africa, it is estimated that only 15% of these community health workers are paid for their work. We wouldn't expect a nurse or a physician to go out and perform their job at the highest of their abilities without a fair payment. And why should we be asking this of community health workers when we know that they have demonstrated impact in the outcomes of the improvements of health in our patients? So as we move forward in our global fight against tuberculosis, it is imperative that we recognize and invest in the critical role of community health workers. I'm really excited to share that in the recent community health symposium held in Liberia at the end of March of this year, there was a huge acknowledgement and recognition of the instrumental role that community health workers have in saving lives and reducing the burden of this devastating disease. I invite you to read what is now known as the Monrovia Call to Action, which sets the roadmap for the professionalization of community health workers, calls on global leaders and public health institutions to really integrate this group of providers into the formal healthcare system to make sure that there's a continuum of care from the doorsteps of the households of these communities all the way to the hospitals in the cities. Because we know that continuum of care is the only way in which we can make sure that tuberculosis becomes a disease of the past. So I just want to conclude by saying that by investing in the skills, the supervision, supplies, salaries, and the integration into the broader healthcare system, community health workers can make sure and can be a part of the team that ensures that no one is left behind in our pursuit of a world free from tuberculosis. Thank you.
Thank you, Paco. It's really good to hear about your personal experience in Mexico in delivering TB care at the community level. That was fascinating to hear and inspiring. And you shared the inspiration from the meeting in Monrovia that you referred to, which really laid out what we need to do to strengthen the community health workers. If everyone haven't noticed that link that I put into the chat, have a look at that statement, because it's a really great list of what the world needs to do to strengthen the community health workers so that they can play the role that we know we need them to play when it comes to the fight against TB and delivering quality care to everyone in need across the communities. We'll come back to you in the Q&A, I'm sure, on some of these topics. Everyone be thinking about your questions and put them in the Q&A box there, and we're going to get to those very shortly. So next we have another fascinating speaker that we've brought to you. Daniela Puma Abarca is a registered nurse and public health professional with Socios en Salud in Lima, Peru. Daniela, over to you. Thanks for being with us today.
Muchas gracias por la oportunidad de poder presentar el día de hoy algunas ideas importantes para las necesidades políticas que tenemos. Voy a compartir mi pantalla. Por favor, ¿me confirman que se puede ver?
Yes, just fine. Thank you.
Ok, muchas gracias. Bueno, el día de hoy vengo a compartir con ustedes esta presentación pequeña sobre las principales necesidades políticas que se tienen, ¿no? Como personal de salud y como enfermera es el papel que yo desarrollo aquí en Socios en Salud como coordinadora de proyectos. Entonces, si hablamos un poco de qué es o cómo podemos nosotros abordar el tema de tuberculosis, pues aquí en Socios en Salud estamos basados en lo que es la iniciativa 0TB. Esta iniciativa nos ayuda a ordenar un poco estas actividades en 3 componentes básicos. El primer componente es el componente de búsqueda, ¿no? Es las actividades de búsqueda que ya no es o ya no debería ser esta búsqueda pasiva, sino esta búsqueda activa, ir a la comunidad, a realizar esta búsqueda de las personas que deben de tener un diagnóstico de tuberculosis, pero que no tienen el diagnóstico por el momento y por lo cual no pueden iniciar tratamiento, ¿no? Esta búsqueda también debe de comprometerse a encontrar el mayor número de casos, ser lo más sensible posible. Entonces, debemos de ahí también evaluar cómo podemos hacer estos tamizajes, ¿no? Debemos de tener la tecnología necesaria, como las máquinas de rayos X, que ahora la Organización Mundial de la Salud lo recomienda. Tenemos que ir mucho más de pensar que la tuberculosis está relacionada solo con la tos, ¿no? Si bien es cierto, hay una relación que ya se conoce, pero tendríamos que buscar un poco más allá, ¿no? Otra actividad que, bueno, estamos muy relacionados para hacer tratamiento integral de la tuberculosis es el componente tratar. En el componente tratar, pues la palabra nos relaciona mucho al tema del medicamento. Y ciertamente es ello. Necesitamos medicamentos, que sean medicamentos principalmente orales, que sean los medicamentos necesarios para tratar a la persona que tiene tuberculosis según la tuberculosis que tenga, ¿no? Si es sensible, si es resistente. Pero este tratamiento también incluye el hecho de que se tiene que tener en cuenta que la persona necesita tratarse por su salud mental, necesita tratarse y tener un soporte nutricional, un soporte social, un soporte económico, sabiendo que la tuberculosis tiene muchas ramas, ¿no? Es multifactorial. Entonces necesitamos tratar a la persona de manera integral. Y la prevención es algo que todavía no se toma de todo en cuenta, porque bueno, siempre es la cola de toda la tuberculosis, es algo que no se ve mucho, pero necesitamos prevenir, ¿no? Necesitamos tener herramientas nosotros como personal de salud para identificar las personas que están en riesgo de tuberculosis y hacer esta prevención. En el marco de esto, pues tenemos que responder la pregunta que se me ha asignado para poderles ahora explicar un poco las ideas que tenemos desde aquí en Perú, ¿no? ¿Qué son las principales necesidades políticas que tenemos? Creo que la principal necesidad se basa en que la tuberculosis debe incluirse en las agendas de gobierno como tema principal, ¿no? Es un tema en el cual involucra muchos tópicos que necesitamos ver. El primero es la necesidad de invertir en tuberculosis, invertir en el personal que trabaja en tuberculosis. Lamentablemente, al menos aquí en el Perú, el programa de tuberculosis, cuando uno ingresa a algún centro de salud y hospital, es el último programa en el cual uno piensa trabajar, ¿no? Para el personal de salud. Uno, por el riesgo que tienes y porque no siempre te dan el material necesario para proteger. Y por otro lado, porque las remuneraciones son muy bajas, ¿no? A pesar de que tienes un riesgo mucho mayor que trabajando en otras áreas, las remuneraciones son muy bajas. Entonces, el personal que quiere que trabajar para tuberculosis es un personal muy poco en cantidad y que todavía tampoco tiene las capacidades necesarias porque no hay una capacitación. Y cuando hay esta capacitación, el personal, tenemos el problema de mucha rotación, ¿no? El personal que ya capacitaste rota hacia otra área porque pues hay mayor remuneraciones en otra área y prefieren el trabajo en otra área. Entonces, si vemos nosotros que es un derecho de estas personas afectadas de tuberculosis recibir la calidad de atención, necesitamos invertir en personal, en recurso humano. Otra de las cosas que tenemos que tener en cuenta también ahí es de que el financiamiento es muy poco para tuberculosis. En el Perú, año a año se lucha para que el financiamiento crezca. Lamentablemente siempre va hacia abajo, ¿no? Disminuye el financiamiento y también se ve que mientras uno diagnostica más casos, a veces como que la autoridad tampoco lo ve bien, ¿no? Piensa que diagnosticando más no está bien, no lo acepto, ¿no? Entonces, no se termina de entender que a más diagnóstico, pues puedes controlar mayor la enfermedad, ¿no? Otro punto que también quería tocar hoy es el tema del acceso universal a los servicios de salud, el derecho a la salud, ¿no? Esa necesidad que necesitamos nosotros de tener este acceso como personas y que la persona afectada de tuberculosis necesita tener. Pues eso también nos limita mucho la respuesta como personal de salud. Aquí en Perú, como en muchos países, pero bueno, aquí tenemos mucha migración, ¿no? En los últimos años ha habido mucha migración. En estos momentos tenemos problemas de migración en nuestras fronteras y lamentablemente la población migrante que se encuentra en Lima, sobre todo en la costa del Perú, lo primero que llega o llegan con una inmunidad muy deprimida y la primera enfermedad que pueden tener ellos o estar en riesgo es de tuberculosis. Y lamentablemente no tenemos en estos momentos un aseguramiento universal para ellos en el tema de TB, porque si bien es cierto, pueden tener tratamiento, pueden tener algún tipo de exámenes, no involucra todo, ¿no? Entonces, la población migrante en el Perú no puede acceder a todas las necesidades que debería tener cobertura por el programa de tuberculosis, ¿no? Por un tema, pues, de leyes, de legislaciones, ¿no? Que eso también, si controlamos a esta persona migrante que tiene tuberculosis, la enfermedad, pues la transmisión también se va a controlar por un tema, pues, de salud pública y de derechos humanos, debería de tener acceso, pero pues no lo tiene. Y nosotros como personal de salud nos quedamos a la mitad del camino en el tratamiento de estas personas muchas veces. También algo que tenemos que tener en cuenta es la inclusión de las organizaciones civiles. Estas organizaciones civiles que nos ayudan, que son organizaciones de afectados de tuberculosis, ONGs, entre otros grupos, que nos pueden proporcionar este apoyo en el cual, pues, Paco hablaba hace algún momento, las agentes comunitarias de salud, que nos pueden ayudar en esta lucha. Entonces, también nosotros pensar que si el personal de salud solo puede trabajar de manera individual, estamos equivocados. Necesitamos trabajar para la comunidad y con la comunidad. Ya basándonos en estos pilares que les había mencionado inicialmente de buscar, tratar y prevenir, en verdad las necesidades políticas son muchas, pero he colocado las principales. En búsqueda necesitamos incrementar esta búsqueda activa, buscar ir a la comunidad, pero usando nuevas tecnologías, ¿no? Entonces necesitamos herramientas para poder hacer el diagnóstico y herramientas que nos permitan ser más sensibles al diagnóstico. Aquí en el Perú aún tenemos como prueba estándar para un control de tuberculosis la baciloscopía, donde sabemos que no nos ayuda a diagnosticar todas las personas afectadas. Tenemos ya pruebas moleculares, pero es todavía muy limitado y está limitado a algunas poblaciones vulnerables. Y no nos permite este diagnóstico y cerrar la brecha diagnóstica que nos está recomendando pues la Organización Mundial de la Salud, ¿no? Tenemos que incluir otras poblaciones vulnerables, que quizás las conocemos, pero no están incluyéndose dentro de la priorización del diagnóstico. Aquí en Socios en Salud, por ejemplo, hemos comenzado a trabajar en búsqueda activa de tuberculosis con población trans. Esta población trans que es muy vulnerable, yo diría que es 3 o 4 veces más vulnerable, porque existe mucho estigma por estas personas, más si tienen tuberculosis, más si tienen alguna comorbilidad. En ello, entonces, nosotros tenemos que identificar este grupo de personas a las cuales faltan llegar. En el grupo de tratar, pues vamos a nosotros identificar estos grupos que tienen riesgo a no adherencia y también necesitamos abogar para que nacionalmente se involucre o se implementen intervenciones para estas personas que consumen drogas, personas que habitan en la calle, que muchas veces no se prioriza. En el tema de prevenir, necesitamos promover esta prevención del tratamiento, ¿no? No solo el grupo de contactos, sino esta población vulnerable que nos está faltando llegar, abogar por un nuevo tratamiento y regímenes de tratamiento que lleguen a nuestro país y asimismo incluir, por ejemplo, algunos otros estudios. Hemos tenido una pandemia hace poco en la cual tenemos en un año varias vacunas a disposición, mientras en tuberculosis solo tenemos una que se ha desarrollado ya hace 100 años, ¿no? Tenemos mucho por hacer, pero creo que las ganas y el entusiasmo de seguir trabajando por tuberculosis en los quienes trabajamos, pues va a continuar. Bueno, eso sería todo. Muchas gracias por su atención.
Thank you so much, Daniela. It was a really fascinating presentation of your work in Peru because you've presented a really comprehensive approach to TB. So you talked about the urgency of addressing mental health services, of addressing nutrition needs, and addressing prevention. We often think of let's treat TB. Well, yes, of course, but let's prevent it as well. So, and I really appreciated how you addressed the needs of the migrants as well. That was a really key theme that you brought forward, of migrants who have arrived to Peru but are not fully covered by services. The need for additional financing, because you mentioned financing has been lagging behind and even going down. And so that's a real concern. And you also mentioned the importance of investing in the staff. And you mentioned a couple of really practical issues that are affecting the actual workers who are delivering TB services. You talked about the risks that they face on the job, and the low remuneration that they receive and lack of training, and the turnover. So you'll have issues with retention. And that, I think, is something that we've got to address if we want to reach everyone in need with TB services and engage all the providers. So thank you again for that really interesting presentation. We'll come back to you in the Q&A. Everyone, I want to remind you again, think of the questions that you want to be asking these experts that we've gathered for you here today. So our last speaker is a physician based in India with a program called REACH. And their name is Ramya Anantakrishnan. Ramya, I'm going to turn it over to you. Thanks for joining us today.
Thank you, David, and a very good morning, afternoon, and evening to all the people who have joined us in this webinar. I'm just going to share my screen and yeah, can you confirm whether you're able to see the screen?
Yeah, it looks just fine. Thank you.
Okay. Yeah. Again, very happy to interact with all of you through this webinar, and thanks for the opportunity, Petra. So I'm going to be talking about, when we talk about engaging all care providers, I think for reaching the last mile, it's very important that the community health workers are engaged, and these community health workers play a very critical role in taking our services in the TB program to the last mile. So today I'm going to be specifically focusing on three groups of people. The TB Nanban. Nanban means a friend in local language, the women TB leader and the TB champion, and the kind of role that they have been playing in contributing towards TB care and prevention in India. So if you look at the TB Nanban. So the TB Nanban, they play a critical role with respect to private sector engagement. And this is an initiative that is being run in Chennai, a city which has about 8.6 million population, and the private sector engagement model builds on private-private partnership. And as you can see at the pivotal of this private sector engagement, because we were talking about how to engage all care providers, and when we talk about all care providers, I think we need to engage all the people in the private sector, meaning a practitioner, a private hospital, a lab, a chemist. So every provider needs to be engaged, and pivotal to this private sector engagement model is the Nakshatra Center, which is basically a public-private partnership center, and that is at the heart and soul of this network. Today, the Chennai city in south of India has about 40 centers across the country, across the city. As you can see, the private sector engagement in Chennai engages all care providers in the private sector for providing the continuum of care to people with TB and their family. These centers provide a free X-ray, free CB-NAT, in fact, free NCD screening also, and treatment adherence support is also provided to the people in the private sector. So this center is manned by the TB Nanban, who is the soul behind this entire initiative, because the TB Nanban is responsible for all the people who get referred from the private sector to complete the diagnostic and the care cascade. So as you can see these photographs, you can see TB Nanban providing counseling and support to a person with TB, and she's also playing a very important role in motivating a private practitioner and engaging them during World TB Day. Another picture here shows how the TB Nanban is speaking and engaging the private pharmacies to participate in TB care and prevention. And the photographs below shows the house visits, the home visits that this community health worker does, and enables every person to actually get the last mile treatment. And the TB Nanban plays a very critical role in providing the psychosocial support that very often is missing in clinical TB management, and to the fact that people with TB look forward to the visits at the clinics, because they are able to receive that psychosocial support. They are able to speak to the TB Nanban and get care. So this through this initiative between 2017 to 2022, through the TB Nanbans, we were able to provide support to more than 52,000 people with symptoms of TB. More than close to 20,000 free chest X-rays were done, a similar number for CB-NAT, and nearly 20,000 people with TB were provided care and support. And not only these people with TB, but their family also were provided screening, were also provided NCD screening, and we've been able to achieve a good treatment success rate of more than 90%, thanks to the efforts by these TB Nanbans working at the facility level. Now, moving on to another frontline healthcare provider. This was an initiative which we implemented through the Stop TB partnership. And we created these, developed these women TB leaders who were basically people in the community who were trained in the comfort of their homes through a IVRS-based telephonic counseling, and they were posted in health facilities to screen all the people who come for whatever symptoms. They were all screened for TB, and once they were screened for TB, they were fast-tracked to get TB diagnosis and treatment. So this was a group of healthcare providers, women TB leaders, who were trained from within their local communities. And as you can see, it was not just a phone-based training, but we also equipped them for a role beyond TB. So they were also trained on aspects of financial literacy, on non-communicable diseases, even financial empowerment, self-defense, and as you can see a photograph here on CPR, life skills, etc. So I think this was truly a very fascinating journey of a person in the community, particularly a woman, because we know that there is so much of gender differences when we talk about access to care and access to diagnosis. So these women TB leaders played a very critical role in improving and providing access to people in their communities. And and what is very heartening is that even beyond the project period, they continue to work. They continue to work with the public health system and continue to serve the communities from which they come from. And today they are in fact becoming recognized leaders within their own communities. The third instance of how a frontline healthcare provider is playing a critical role is this whole community engagement that we have been fostering in India, where we trained thousands of TB survivors as TB champions. And I just want to share a few of learnings from this initiative. So when you look at the overall process, today, the TB survivors as TB champions are in the map of TB program, playing a very critical role in various platforms. So the process was, we identified the TB survivors, we built their capacities through theory-based workshops, and then initiated a mentorship program where they actually went to their communities, to the health facilities, and started working with other people with TB. They also got into groups called the survivor-led networks, and these are networks of TB survivors. And we also created opportunities for these TB champions to speak at various platforms. And today, the TB champions play a critical role in raising awareness of TB in their communities, in reducing stigma in the community, because there's nothing more powerful than a person with TB who's cured comes out and say, look, I had TB and you could also get cured like me. And they use their own personal stories to motivate and encourage other people with TB to complete their treatment successfully. Today, TB champions play a critical role in advocacy, in providing real-time feedback to the health system as part of the community monitoring. And overall, they are playing a very critical role in providing that very essential emotional and social support to people affected by TB. So as you can see here, some pictures of how our TB champion work with the communities close to their homes and motivate the people with TB and do go home, meet the family, and especially they play a critical role in reducing the stigma in the family. So they also reach out to the communities and talk to other people in the communities on TB. And today they have become so empowered that they are able to go to their own local leaders and mobilize resources for TB people. Again, as I mentioned, they are playing an important role in mitigating the stigma, discrimination. And as you can see these pictures, these were some of the artwork by the TB champions to express TB stigma. And they use these pictures to motivate communities to reduce stigma on TB. As I mentioned, these TB survivors have got together as networks so that they are able to look at big picture, are able to identify gaps within the delivery of health services and take it to the right people so that these gaps are addressed. Here you can see a picture of how a TB champion is doing community monitoring to improve the quality of care and quality of services. And that is very important if you are looking at strengthening any TB care prevention. So today, we see that these TB champions are playing an important role in taking this accountability framework, the one which we saw Hannah present. I think it's important that the community also owns it. And today the TB champions are owning it from the in a truly bottoms-up approach. These TB champions meeting their local leaders, their own leaders in their communities, in their villages. And today they become empowered enough and to meet them, to talk to them about the gaps, to ask them to fund for things like x-rays or weighing machines, whatever their community needs. They have become very powerful speakers in various forums, including and are actually sharing the platform with bureaucrats, policymakers, and so on. They are also playing an important role in inviting other people with TB to actually join this journey through video messages and photo messages. And this is what the Unite to Act is one of the initiatives that we are implementing through the Global Fund initiative. And I mean, it's a very busy slide, but more than 200,000 people with TB have received services from TB champions. And similarly, the Allies project is another initiative which we are implementing through the USAID support. And as you can see here, about 177,000 people have been reached through the various community mobilization initiatives. So today, across the country, there are close to more than thousands of TB champions who are committed to working with the National TB Program. And through this presentation, I was able to showcase the TB Nanban, the TB champion, and the women TB leaders who are the people who help the TB program, any commitment by governments to reach the last mile, and their participation, their inclusion, and their engagement is very, very critical to end TB. So thank you very much, and over to David.
Thank you, Dr. Ananthakrishnan. That was a fascinating presentation. You really highlighted the role of the community in achieving real results, in connecting people to the services that they need. The role of that TB Nanban. It seems like every person affected by TB needs a Nanban or needs a friend. And that's what your program talked about and you're providing. So it's fascinating to hear about the role that the community is playing. Often we think of who's the hero in providing TB services, who's the frontline worker. Well, in this case, not necessarily wearing a white coat, but right from the community, and that work that they're performing as TB champions is really critical in reducing stigma and connecting people to the services that they need and overcoming the barriers that they face. So thank you so much for your presentation. We're going to shift now to Q&A. So this is where I'm going to ask the audience members, you've been waiting patiently to ask your questions. And I'm going to ask you to put into the Q&A box. If you look at the very bottom of your screen, you'll see that little button that says Q&A. That's where you need to ask a question. We'll start there. And we've got, looks like a few questions that we can turn to here. looks like we have some questions directly for Dr. Ramakrishnan, Anantakrishnan, I'm sorry, about the TB non-bond. First question there, how is the TB non-bond connected with the public sector? And there's a related question, which is, what are some of the motivating factors for community mentors to continue working beyond the project? Are they incentivized? Meaning, do they receive some kind of financial support or some kind of incentive to continue working with the program? Over to you, Dr. Anantakrishnan.
Yeah, thank you, David. So in response to the first question, each TB non-bond is linked with their public sector counterpart. So there is the private sector, there is the public sector. The TB non-bond works in the private sector. And there is a public sector counterpart called the community health worker or the senior treatment supervisor. So they work closely with the senior treatment supervisor of that same community or the district or the sub-district because they have to license with them for testing because we provide free testing by testing in the public sector. Similarly, the free drugs are obtained from the public sector. So they work very closely with the public sector counterpart at a sub-district level. Second, the motivating factor, yes, all the initiatives, the program does have a small honorarium as part of the program design, and this honorarium is more towards helping them for travel because they need to undertake home visits, they need to go to the community. It's a very nominal kind of honorarium. And they are not incentivized because, I mean, it's not that a person who does more gets, because this expense is more towards meeting their travel expenses. The third question is how often you see, again, all these people, the kind of rapport that they are able to build is very important. And in fact, they often become like family members, and any family functions that happens in their home, be it a marriage or a birthday. So often these healthcare providers are invited because they form part of their family, and that is the rapport that is built. And these TB champions, particularly, the single biggest motivating factor is the suffering they had through the TB journey. And so they do not want others also to face the same challenge. And that is something which will help them to work beyond any project period. Thank you.
Thank you very much. So I'm just going to look in the chat here just to make sure we don't have any questions that have been put in there. It looks like no. Okay. I'm going to ask the audience, ask some questions here. We have 4 amazing experts that have come together to talk to you about the importance of engaging all providers, not just the public sector, but also the private sector providers, and also make sure that when we talk about providers, we're talking about human beings. We're talking about workers who need to be remunerated, need to be supported. In the case of community members that we just talked about, incentivized, that needs to be budgeted for. So there's some critical needs there that go together. Okay, so I'm just going to ask again the audience to ask a few questions. Maybe what I'll do is I'll just turn and ask a couple of questions of the panel that we've prepared ahead of time. As we look at engaging primary health, there's a real call from the TB community. The link I put in at the very beginning is a list of demands that the TB community, affected community, is making of decision makers. One of them is integration of TB services with primary health care. What do you see as what needs to happen for that to take place to make sure we have people-centered TB care? In particular, how are we going to properly engage with the private providers, the nurses, the community health workers, and what lessons can we draw in terms of successful measures to ensure that we have strong implementation of these programs, and including as we look at critical issues of incentives and salaries and budgeting for those. I'm going to open it up for the panel to add some comments and reflections on those topics. Anything from you you'd like to say to add to your earlier remarks, Monica or Paco or Daniela?
So maybe I can start, and I think others can perhaps add. But just to underline that indeed this is a major priority. We have seen systematically that, if you look at 10 years ago, there was very much this focus, and maybe rightly so, given that progress on ending TB was slow, that there was this concerted push, right, with strong TB programs, especially in high TB burden countries, where we knew that there was this huge burden of patients. But increasingly, as we now join together the overall march, we've seen a lot of progress made with 74 million lives saved since 2000. We've seen that there are lessons that I also shared in my presentation that, the TB community has made strong contributions, or the TB system has made, TB programs have made strong contributions to strengthening health systems. And we saw this during the COVID-19 pandemic, whether it was contact tracing, infection prevention and control, the knowledge of health workers, especially in dealing with infection like TB, which is so similar to COVID-19, in dealing with airborne infections is significant. So we've seen that the contribution there is strong. So as we look at primary health care and UHC, the resounding cry really has been that it needs to be as integrated as possible. And there are multiple routes to enable this. And this is what we're promoting. And we're also promoting linked to pandemic preparedness, that, engaging all care providers needs to be strongly in focus, given that it goes both ways, right? Both towards achieving UHC as well as ending the TB epidemic. So we would really see that strong link. So I'll stop there, and maybe others would like to add from their personal experiences.
I see we do have a question from the audience, so I think I'm going to turn to that question. Rajesh Sood says TB mortality is a tracer of UHC coverage. What needs to be done to save the lives of people with TB under the broader framework of health system strengthening? Because vertical programs can address morbidity, but addressing deaths needs more than the TB program. And he mentions that the seriousness of the community is not yet the same as COVID. I think as was understood with COVID. So I'm going to turn to the panel. Comments on that from Paco or Daniela?
Sure, I can quickly jump on this, and I think that Monica made a great. She put up the framework for this actually for this answer, because when we're talking about tuberculosis detection, prevention, response, we're not just talking about tuberculosis, right? We know many of these patients concurrently have HIV or have a condition that makes them susceptible for TB, right? So I think that when we're talking about trying to prevent, detect, and respond and eradicate tuberculosis, we should be thinking not only on the vertical pillars of it, but we also should be thinking about the integration of the services, because it makes more sense for us to leverage the infrastructure and the resources we already have in place for individual diseases, namely tuberculosis. It can be HIV, it can be malaria, and so on. But when we think about it holistically, we can pull those infrastructure and those resources to treat the person in a comprehensive way. Because when, as many of you know, when you see a patient or when you're seeing a community member, they're just not going to come and say, I only have TB and I'm only going to see you, right? Like they come with an array of different problems, and the health systems should also respond in that way. So I think that when we address COVID, we should also be thinking about tuberculosis, and we should also be thinking about other infectious diseases. That's the only way I can see us moving forward. And I think that my last comment is that COVID came to one of the we can say good things about COVID is that it brought a renewed interest in infectious diseases. And I think we should really, as a community, we should be really leaning into that to energize again the fight against tuberculosis, and making sure that medicines are accessible, treatments are accessible, testing is accessible for everyone, regardless of where they are. Thank you.
Yeah, thank you. That's a really great reflection. And I want to turn to Daniela Puma. I see you nodding in response to what Paco was just saying. I wonder if you might add any comments at this point.
Sí, bueno, mi comentario final quizás para este cierre es la necesidad del trabajo en equipo, ¿no? Como mencionó tanto Paco como Mónica, esa necesidad de ver a la persona afectada por tuberculosis que tiene muchas necesidades de salud mental, de nutrición, verla de esa manera y por lo tanto fortalecer el recurso humano que tenemos en tuberculosis, como ya les había mencionado en la presentación. Necesitamos que esa atención sea una atención primaria, ¿no? Aquí, les cuento, en el Perú hubo un error muy grande inicial para la atención de COVID, que fue fortalecer hospitales, 1 o 2 hospitales inicialmente, ¿no? Entonces, toda la atención se centralizó en los hospitales y la atención primaria quedó sin apoyo como debería haberse hecho. Entonces, la atención centralizada en el hospital es mucho más difícil. Tenemos también aquí en el Perú algunos problemas, como por ejemplo el tratamiento de TB-VIH no puede atenderse en atención primaria, por ejemplo, aquí. Entonces, es una necesidad que creo que hay no solo con TB-VIH, con TB-diabetes, que es una necesidad que la cual la respuesta, si viene de la atención primaria, creo que sería mucho mejor, ¿no? Pero lamentablemente todavía no tenemos esos financiamientos y ese fortalecimiento que la necesidad se tiene en el momento, ¿no? E inicialmente también mencionar que deberíamos de tener esta facilidad que nos ha dejado el COVID. En el Perú tenemos diversos hospitales que han sido fortalecidos para el control de COVID. Tenemos UCI, tenemos algunos lugares o unidades que las cuales deberían ya usarse para tuberculosis, porque prácticamente es un control muy similar, si no es igual. Entonces, nos falta ver que los gobiernos de nuestros países puedan ver eso como una facilidad, ¿no? Como una ventaja. Ese sería mi comentario. Muchas gracias.
Yeah, thank you very much. That's a really it's interesting to hear your perspective on how these pieces fit together. I wonder if you might expand a little bit on what you mentioned in your presentation. You talked about the importance of investing in the health workforce, and you talked about the risks that they're facing in working on TB and how that is a challenge for them. I noticed that in Peru, at the height of the COVID pandemic 2 years ago, there was a very strong protest by health workers related to risks and remuneration. Could you talk a little bit about their access to training and the retention issues? You train someone in TB and then they may leave TB work or migrate to a high-income country. How do you see it addressing those issues?
Bueno, en verdad las huelgas que tenemos aquí por el personal de salud son continuas, con paralizaciones parciales, y esto también demandando una mejor remuneración, un mejor derecho. Tenemos aquí puestos de salud que no son estables, ¿no? Que fueron contratados por COVID y que lamentablemente no todos se han mantenido. Hemos tenido personal de tuberculosis que migró a COVID y que, bueno, fue por una mejor remuneración, ¿no? Tenemos personal que migra, mucho personal de salud, y pues en total por enfermería no cubrimos la necesidad en estos momentos, ni el personal médico tampoco, a lo que requiere la población. Y esto hablando solo de Lima o ciudades que están en la costa. Ciudades o pueblos indígenas, poblaciones en la sierra de Perú, pues no cuentan con un personal de salud completo. En algunas ocasiones hay un servicio rural que realizamos todo el personal de salud al término de nuestros estudios universitarios, y son ellos quienes dan la respuesta en estas zonas alejadas del Perú. Adicionalmente, pues no siempre se cuenta con un equipo de protección para dar al menos una respuesta necesaria. No contamos muchas veces con medicamentos, y con el recurso limitado que tenemos se tiene que dar una respuesta, ¿no? Entonces, eso no es justo ni tampoco viable para el personal de salud, ni tampoco para las personas afectadas de tuberculosis o los usuarios que van hacia pidiendo algún servicio de salud, ¿no?
You've touched on a number of issues there when it comes to the realities that we're facing when it comes to the health system and the provision of services, including in rural areas. And so I think those are really critical. So we've reached the conclusion of our panel here, but I'm going to ask each panel member to offer your final reflection. What do you see as the key takeaway from this discussion, where we've touched on a number of different topics in terms of engaging with all providers, making sure we have all hands on deck, that phrase meaning that we need everyone involved if we're going to end TB, including the private sector providers, the public sector providers, the community health workers, and meeting their needs, because otherwise we're just not going to succeed. So I'm just going to ask everyone to give what's your key takeaway for the audience today? Let's turn to Monica first.
Thanks for that, David, and thanks to all the participants who've joined today. I mean, you've summarized the main takeaway, I think, for all of us about having all hands on deck. To add to that, I would say that one of the takeaways is that no matter where a person affected with TB, their families, or you know, a person who is ill accesses care, they should be receiving the highest quality of care possible. This, I think, is the bottom line for all the work that we do, and this links to our work on ending TB, on achieving universal health coverage, and preparing for future pandemics. And in this sense, what is important is having a very strong health workforce and an integrated workforce across all sectors, basically leveraging resources across health, beyond health, the communities, the private sector. We really need to make sure we're all engaged as we move towards, as Ramya said, the last mile to end TB, the last mile to reach our target of universal health coverage. I'll stop there. Thank you.
Thank you. Over to you, Paco.
Thank you. I completely agree with what Monica has said, and to not repeat myself, I would say that to truly achieve universal health coverage, pandemic preparedness and response, we need to be thinking holistically. We cannot keep doing business as usual. COVID has showed us that we cannot be healthy and safe until everyone is healthy and safe. That includes people at the farthest away and most vulnerable communities that we have. So my key takeaway from all of this is that we should be investing in professional community health workers. They're the first point of contact into the formal healthcare system. They're the first responders, and they live in the places where infectious diseases like tuberculosis start and end. And if we really want to make sure that we make tuberculosis a thing of the past, we should be investing at the point where communities live, making sure that the challenges they face are diminished and access to high quality care is readily accessible to all. Thank you.
Thank you, Paco. And now I'm going to turn to Daniela. Any additional comments that you would like to make, or are the key takeaway message from your perspective?
Y mi mensaje final sería que necesitamos abogar para que nuestros gobiernos fortalezcan los recursos que tenemos en cada uno de los países. Recursos humanos, personal de salud capacitado, personal de salud que pueda responder a la lucha contra la tuberculosis, que se les pueda dar insumo al personal que se necesite, pruebas sensibles, tratamientos adecuados para ellos, y que también el personal de salud vea esta integralidad que mis compañeros que me han antecedido vean, ¿no? Esta integralidad, que luchen a favor de la tuberculosis y que también no están solos, que incluyen también a las organizaciones sociales y afectados. Gracias.
Thank you. Gracias por todo, por su participación. And over to you, Dr. Ananta Krishnan. What is your final reflection on our discussion today?
Yeah, thank you. I think everybody else covered most of the points. I think if we are to move towards to integrated care and universal health coverage philosophy, we need to move from TB specific care to holistic care. Which means every provider, be it those who see TB, those who don't see TB, everybody have to come on board. And I think that's very important for true universal health coverage. And lastly, I think there should be a mutual respect for every provider. They need to be valued, respected, and because every one of them is critical. I mean, everyone is a jigsaw piece. And all of us come together to actually complete the jigsaw puzzle, and that's the only way we can end TB. Thank you.
Thank you. You have it there. We all form a piece in the puzzle here in terms of ending TB. The fantastic panel that we have here assembled, as well as the audience, it's going to take all of us working together to end this disease, and we're going to take these issues to this really critical UN meeting that's happening in September and bring forward these expectations and demands coming from the community, coming from our experts, coming from the health workers themselves. So thanks very much to our panel. Petra, I'm going to turn it over to you to give our closing.
Thanks, everyone. Really enjoyed this panel. I'm very happy that we recorded it to provide it to the rest of our community. Thanks everyone who spoke. Thank you, David, for excellent moderation. Thank you, Vanessa. I want to do a shout out to our wonderful translator who made this available in Spanish and in English. So as I said, we will be providing all the recordings, all the presentations on our website. We'll do a short report, and you will also find a live feed on Twitter if you are interested in finding some of the wonderful quotes. Very excited about this topic and looking forward to see how we can continue this communication. Really, all of you are doing the hardcore work at the heart of our health systems, each of you in your own way. And I love the jigsaw puzzle. We need to support each other to find that energy to end TB. And I want to thank everyone. Wonderful webinar for today, and looking forward to seeing you in the future. For those participants, thank you for joining and sticking through. I have one more last question. I'm gonna just share a quick poll if I can find it right now. And then if you can give us a few quick feedbacks, we would love to hear from you. Please reach out anytime, and see you next time. We have a webinar on upcoming Monday on the 22nd, talking about the universal access to diagnostics. Again, we're going to be focusing on how can we make diagnostics and all these tools available to all healthcare providers. And so if you are interested, join us on Monday. And with that, I would like to say goodbye. Muchas gracias. Thank you very much. And looking forward to seeing you again soon.
Thanks, everyone.
Thank you, everyone.
Thank you, everyone. Bye.
Thank you so much.
Thank you all. Thank you.
Thanks, everyone.